panelist for today. Anastasia Albanese-O'Neill transitioned to a career in diabetes care, education, and research in 2008. And she currently serves as Associate Vice President, Type 1 Diabetes Education and Clinical Implementation at JDRF International, with a focus on education and awareness about early detection of type 1 diabetes and clinical trial participation. That is a mouthful already, Anastasia. I'm so impressed. She has been a passionate diabetes advocate since 2002, and in this capacity has appeared at congressional hearings, the White House, and in the Florida legislature. She's a volunteer founder of a Florida-based diabetes education nonprofit organization, Diabetes Toolkit. And prior to working in diabetes care, she was a marketing executive for Southwest Airlines, and importantly, was chosen as the 2023 Diabetes Care and Education Specialist of the Year by CDCES. So congratulations to you. What a year it's been.
Thank you. It has been a busy year, but wonderful being out in the community with diabetes care and education specialists and everybody in the type 1 diabetes community. It's wonderful to be here.
Well, we are so happy to welcome you and thank you for your time today. We're going to talk about a really important topic, and that is the staging of diabetes and screening for type 1 diabetes. So there's been a lot of talk around this, which can result in early identification of diabetes before symptoms arise or before insulin is required. So we'd love you to share more about this and really just start with the stages of diabetes and some of those characteristics of each stage. For a lot of those listening, this may be the first that they've heard of a stage of diabetes.
Absolutely. And honestly, if you went to medical school or nursing school more than 10 years ago, you're not familiar with the staging of type 1 diabetes because it wasn't in the medical literature. And I'm going to call myself guilty as charged. I taught pathophysiology, or the basis of disease, in the College of Nursing at the University of Florida. And I didn't talk about the staging criteria when I taught that class. So if I could go back right to the 2016 Anastasia and say, you should have done that differently, I would, but let's talk staging. So I think most people think that type 1 diabetes has two stages. You have it or you don't, right? You don't have it, or then you require insulin because your body can't produce enough and you have really high blood sugars. Some people might consider what we call the honeymoon phase, where at the beginning of the diagnosis, you don't require as much insulin, and some people require very little at all. But take that thinking and put it in the past, because what we know now is we can detect type 1 diabetes months and even years in some cases before people require insulin replacement. This is thanks to decades of research to identify markers in the blood that are called autoantibodies. So these aren't genetic markers. What they tell us is that the immune system has misidentified the insulin-producing cells in the pancreas, and it's working to destroy them. And again, we can see this way in advance. So what are those stages? There are 4 different autoantibodies. I won't get into their names because they're really long and complicated, but there are 4 that we look for with a very simple blood test. And this staging was published in 2015. So there are 3. So keep 3 as a kind of a nice number. The first is you've got 2 or more of these autoantibodies that are confirmed. So you don't just test once, you test twice or more, and we can see them, but your blood sugars are completely normal and there are absolutely no symptoms. So without the testing, you can't see anything at all. That's stage 1. Stage 2, those 2 autoantibodies are still present, but we can start to see changes in blood sugar. The body's starting to lose its ability to regulate blood sugar because of the destruction of those insulin-producing cells. So you've got high blood sugar, but the thing is, it's not when you expect it. Most people are going to check a fasting blood sugar. We often see these highs after meals. Because you eat that big carb load and the body can't keep up with it. Stage 3 is that typical diagnosis that you see in the medical literature. High blood sugar, symptoms like thirst, frequent urination. People may start wetting the bed, weight loss, fatigue. That's stage 3. So what we know now is we can see it long before stage 3, and we can actually have tools to do something about it. So stages 1, 2, and 3. And there's a lot of information that I can share online where you can go review this after today.
No, that's amazing. And to see it when the immune system is actually starting to attack those cells in the pancreas, for a screening to be able to detect that level of information. What exactly, I know we've got a lot of folks joining us today who are really curious about this. Most of them are already diagnosed. Some of them have children who've been diagnosed. It's a new topic, right? Screening is such a new topic in diabetes. And so what does it mean to screen for, to find these stages? And what are the benefits ultimately once you discover this information?
I got to thank you for asking that question. So this is very close to my heart, and it's really one of the reasons I'm in the field. So if you have 2 or more confirmed autoantibodies, and this is straight out of the standards of care in diabetes, if you have 2 or more confirmed autoantibodies, your risk of progression to type 1 diabetes is nearly 100%. I don't say that to scare anybody. I say it because we now have ways to intervene. So let me answer the first part of your question. Having said that, screening means that there's a small sample of blood taken. It can be done with a finger prick, or it can be done usually through phlebotomy, through a blood draw. And the test is for these autoantibodies. Again, these are immune markers that show that the immune system is working in the background to destroy the insulin-producing cells in the pancreas. It's not genetic testing. Most people who get screened, the good news is, because I frightened you with that statistic that if you have 2 or more, you're going to progress to type 1, most people come back negative. Let me say that again. Most people who get tested come back negative. But if you test positive for 2 or more and it's confirmed, there are 3 really significant benefits. The first is we can prevent a really acute complication called diabetic ketoacidosis, or DKA, at diagnosis. And I'm thinking some people listening either experienced that themselves or their child did. My daughter was diagnosed at 16 months. She was diagnosed in DKA, was in the ICU for many days, and it was a really traumatic time for our family. What we now know from decades of research, again, so this isn't just something we think would be good to do, we can reduce DKA risk right now in kids and adolescents. We don't have data on adults. We're working on that. Kids and adolescents in the US experience DKA at diagnosis 40 to 60% of the time, at least half of them, including, again, my own child. We have data from Germany and from the United States that shows that if we screen people, we can get that down in Germany to less than 2%, and in the US less than 5%.
Wow.
So not only the hospital bill aside, but the stress of DKA at diagnosis, the time in the hospital with your family, the worry, we can alleviate that through screening. In my mind, that's justification enough, but there's more. We can also identify people who we can ask to participate in research studies to help us figure out how to delay or prevent the onset of type 1 diabetes. And there were 40 years of research to get the first therapy approved that can do that. It's called teplizumab, MZWV, or Tzield. This is now FDA approved. So people can talk to their doctors about FDA approved therapies. But those first 2 points are really essential. That therapy delays type 1 diabetes 2 to 3 years. We need to figure out a way to prevent it altogether, and we need people to get screened. And of course, we want to protect people from DKA.
And on that topic, can you talk about timing and timing for screening and who's a good candidate? We've got a couple questions coming in.
Yeah, that's a great question. So up until now, screening has really been limited to what we call first-degree relatives. So your parents, your siblings, or your children. And as I mentioned, after our daughter was diagnosed, we all got screened, everybody in the family. And matching the statistics I shared, we all came back negative. So we did not progress, and we don't have an increased risk. I don't know why. There's a different group of clinicians and scientists working on that. So the truth is, I need to back up a little. Most people, and I think this will resonate with people on the call, 90% of the time, there's no family history of type 1 diabetes. It's not like type 2 diabetes, a sister diagnosis where everybody in the family, we can look through the family tree and see aunts and uncles and grandparents and parents. Very different with type 1. 9 out of 10 times, you're the first person to be diagnosed in your family. So at JDRF, we would argue that there should be universal screening for type 1 diabetes, because if we only screen family members, we're going to miss 9 out of 10 people who are going to progress to the diagnosis. And in fact, the country of Italy just passed legislation, I'm not sure how they got this done, where they are going to screen every child in the country of Italy for risk. And I think that's where we're going. Here in the United States right now, if you've got a family connection and you're on this call listening, this is an opportunity to get screened and realize some of the benefits we discussed above, either ruling it in or ruling it out. In our family's case, I have a second child. It was very nice. He was screened multiple times. He actually participated in a study and he came back negative every time. I don't worry about type 1 diabetes anymore for him. And that's a nice kind of relief as a parent. So family members should absolutely get screened. And I think other people who have a family history, this is not in the guidelines, but who have a family history of other autoimmunities or autoimmunity themselves may talk to their doctor about screening. There are amazing research studies where you can do screening for free. And I'm happy to drop those in the chat or direct people to a website where they can learn more.
That's such helpful information. One point of clarification that we've gotten is it early and often? When does screening take place? You mentioned your child did it several times, right?
Yeah.
And we know that type 1 diabetes can happen at multiple ages across the timeline.
Yeah, that's a great question. So I am going to not make an excuse for myself, but based on the evidence, we don't have enough data on adults to tell you how often you should screen as adults. Our information all comes from childhood screening programs. What we think, and from some data that was analyzed using AI, everybody talks about AI in a partnership with IBM, so they've got some computer expertise, was we think that if you screen at the ages, from the publication The Lancet, if you screen at the ages of 2 and 6, and you get negative results, that gets us about 80% there. So we suggest if you screen at the ages of 2 and 6, maybe one more time before the age or around the age of 15. If you're negative all 3 times, the likelihood of progressing is very, very, very low. In the case of adults with a family history, screening once is probably a good idea to rule out those autoantibodies.
Sure. That's super, super helpful. And I know you're now getting into sort of that scientific guidance around screening. Anything you want to share there and just what's on the horizon?
Yeah, so something we've been working on here at JDRF and are really proud of, we were able to partner with experts around the world to think about what guidance do we provide when people come back with a positive result, right? So here we are talking about go out and get screened, but I'm a nurse practitioner by training. I would be hesitant to prescribe a lab if I didn't have written guidance on what to do when I got that result, so that I could provide education to that individual or to that family, so I could provide psychosocial support. Maybe they got a positive result. Maybe they needed more than just my support. And then also, what's the medical follow-up? This group of experts literally from around the globe have been working on that monitoring guidance, and we're hoping to have it across the finish line soon to answer exactly this question: what do you do next? And the key thing is, if you get a positive result, to partner with your doctor to make sure that you're that you reduce that risk for DKA diagnosis. You get the sort of up-to-date options in terms of research and treatment.
And we know that that planning, that being able to have a little bit of reassurance, and also just the piece that you shared about the reduction in DKA being your first, hello, you have diabetes, and now you're in the hospital for days, sometimes weeks, to try to manage it. And in that such an acute and challenging moment in a family's life or in a person's life, to then have all of the education thrown at you at once, all of the information thrown at you at once. So to have the space and the time to really work to understand it. And this is where education is just so important to us as an organization. And I'm so thankful that you've committed your life to it, because it matters. It matters. And it's to be able to do it in a moment where you have a little bit of space in that juncture is so critical.
Yes, yes. I think anytime you get a result you don't want, it's stressful. So I want to acknowledge the anxiety people might feel when they receive a positive result. But what we do know, again, from the literature, from a study called Teddy and others, is that at least for parents, we need more data on the individual screen, and these were children in this case, that distress, that anxiety does wane over time, and people report that they were able to plan. And I just want to put a plug in for research. When we do research, in attempting to preserve the ability to protect your own beta cells, the ones you have left at diagnosis, or to prevent the destruction of those cells, we have to start those studies in people who are already diagnosed because of the question of risk benefit, right? Most of those studies, you have to decide if you're going to enroll in a study to protect your beta cell mass, to prevent the further loss of those cells within 100 days. If you're in the ICU, if you're caught completely sideways with this diagnosis, 100 days goes by really quickly. I remember that time. And
right.
Not only in terms of a sense of calmness when you do have to start thinking about insulin therapy, but also the opportunity to be really informed about, am I going to participate in research at diagnosis? Because we need people to fill those studies. I want to prevent this diagnosis. I don't want anybody to experience what our daughter did at diagnosis. So screening sets up those opportunities. And without it, it's the gateway to those opportunities. Without it, they're not available.
And I think, that gets into, I think this is really important to address, because we have some questions coming in around just the emotion of this. As a parent of an infant right now, oh gosh, does my heart feel One person said, listen, I'm type 1 for 40 years and nervous about getting my children screened. It's emotional. It's incredibly emotional. And so do others go through this? And is that sort of keep you up at night worry? And around specifically this sort of new science coming out around screening, does that sound like something JDRF has heard?
Not only do we hear it, but we live it, because so many people in the organization either live with or a parent of or a partner of somebody with type 1 diabetes. This is very real. And like any decision we make, you need to make an informed decision. So our goal today is just talk about the benefits. Now we have some benefits for the individual who is screened, which we've talked about. We can also talk about the broader benefits for our community. So, it was hard to make a decision. Our son participated in a study called TEDdy. I don't have type 1 diabetes. Our daughter did, but I understand that feeling of guilt. I had guilt. Was it me? Was it something I did as a parent? She was diagnosed at 16 months. I was nervous to screen my son. But I felt like, if not me, who? And I walked through that fear of screening. Now, we were lucky. We got positive results. He was screened 26 times because the study may be a bit excessive.
Negative for the antibodies.
Negative for the antibodies. Yeah,
no, just want to clear. So good news, yes.
Screened and negative. So we got good news. I think the fear is getting that bad news. And then how do I wrestle with that? And I think I want to be really respectful of people living with type 1 who have children and are thinking about how do I do this? How do I wrestle with my own emotions? I guess what I would say is, if you can see it coming, you can do something about it. You can contribute to research to help us. What we want to do is prevent this diagnosis in future diagnoses. And then what I will also say for people who already have type 1, the research in screening is important also for people with established type 1 diabetes. If you give me 2 minutes, I want to explain that.
Absolutely.
Eventually, and you've probably heard about studies in stem cell therapy, where we have infused cells into humans and they produce insulin. And some of the people in these studies are no longer using insulin, not all of them, but some. We are going to get to a point, I believe, and I don't know when, it could be 5, 10, 50 years. I don't make any promises, but we will get to a point where we have replacement therapy. But right now, if you have a cell infusion, that's a foreign tissue. So your body rejects it as not self. Okay, so we're working on a lot of science. So people who take these cell therapies have to take immunosuppressive drugs. So the first thing we want to solve is to get rid of the need to take immunosuppression. But let's say we fix that. Let's say we can infuse cells into the body and the body doesn't recognize them as not self. The immune system says, I'm happy to tolerate you here. Do your job. What people who already have autoimmunity and type 1 diabetes also have is just that, autoimmunity. Their immune system knows how to recognize islet cells, beta cells, insulin-producing cells. So we have to teach that immune system tolerance. And a lot of this work in prevention is doing just that. It's teaching the immune system how to tolerate insulin-producing cells in the pancreas. And so there's a sort of a twofold benefit to the screening work. And it's pretty much for everybody is what we're learning.
To make sure I understand exactly what you're saying, the screening allows for some of that therapy to take place in the interim time. Yes. If you do get a positive result, if you do test positive for those antibodies. Okay, great.
So you can take advantage of a FDA-approved therapy. You can also participate in a research study. We've got a study recruiting right now called Stop T1D. It's with a drug called ATG. You could participate in that study if you're found to be in stage 2. Type 1 diabetes, if you are going to progress, but you don't have those symptoms yet, you haven't progressed to clinical diabetes, we need people to participate in that study. We have a at-diagnosis study called Relay that we need people to think about participating in, and one called Jackpot. I don't know who comes up with these names, but Jackpot, it's a JAK inhibitor. But again, you've got to decide within 100, 120 days whether you're going to do it or not. So if you've screened, you can see it coming, you can participate in a prevention study, or a new diagnosis, you can participate in a study to understand if those therapies preserve the ability to produce insulin. So we need you. We need you, folks. So I'm going to
seeing
be really direct.
No, I'm seeing a lot of folks saying to us now, if not me, then who? What a great line. That this is really inspiring, and that certainly that is an exciting. This is all exciting information. So I really want to thank you from our audience, just who's chiming in. And I want to get to. I want to pivot in a moment to the advocacy piece of this, because of course DPAC is that A, and DPAC is for advocacy. But I do want to make sure we get to a couple of the questions that have been asked, because this is just such an interesting topic. So, have you studied patients with GAD antibody tests that are over 25,000?
So that specific question, I'm not sure what they're getting at.
Okay.
Can you put a little more in the chat? But
GAD,
right, is one of the autoantibodies we screen for.
Okay, great. And then it sounds like that, let's see, we've got somebody mentioned one thing that they tell people getting screened, and the possibility of disease modifying the therapy could get you out of diapers through puberty and through a pregnancy. So just to be able to know that is a potential part of your life moving forward is really good information.
Yeah, let me just underline that. So the therapy that was approved has been shown, this was published in the New England Journal of Medicine, to delay the onset of type 1 diabetes for 2 to 3 years. And again, and there's further research going on, because the study concluded, but they're still following all the people in the study. And now people are actually getting it clinically. Over 100 people have received the drug who are in stage 2 type 1 diabetes, but they've received it at their doctor's office. We want to understand that. But I think what that person was saying in the comments was, what did those 2 to 3 years mean in the life of a person?
Could have gotten out of diapers, could have gotten through puberty, could have gotten through a pregnancy. Yes.
Yeah, my daughter was 16 months when she was diagnosed. There's actually a study recruiting right now called Petite T1D. You can look it up on clinicaltrials.gov in 1 to 7-year-olds for this infusion. And, getting my daughter from 16 months to 4 years, she could have told me she felt low at 4. She couldn't at 16 months. There were a lot of communication that could have happened that didn't. And again, you can apply that to any stage of life. So thank you for that comment, whoever made that in the comments.
Couple more questions. Does screening for antibodies help with any sort of detection or diagnose type 1 diabetes in cases of pancreatic cancer?
Say that again. What was the beginning of that question?
Does screening for antibodies help diagnose type 1 diabetes in cases of pancreatic cancer?
I don't know the answer to that. I don't think so. I think they're different disease pathways. Usually we pick up pancreatic cancer, frankly, too late. That's why the prognosis is so poor. And usually through imaging or some kind of a biopsy or surgery. So they're different pathways. These autoantibodies, in the context we're talking about them, is specific to identifying type 1 diabetes early. And I'm happy to, if you connect me with that person, I'm happy to.
Yeah, I'm sure we're going to have a lot of follow-up here. And for folks who've still got questions, would love to make the connection, because Anastasia is a wealth of information and specializes in education. So this is awesome. And the person who had written earlier about the GAD antibodies was just saying, just has the autoantibodies, but currently doesn't take insulin. So just really, doctor says it's rare, and that maybe wanted to mention that in case that's anybody else's experience who's listening.
So the person with GAD autoantibodies, I am going to encourage you to explore an opportunity to contact TrialNet. It's at trialnet.org. It's a network. You may already know about them, or you may already be participating, but trialnet.org. This is funded through the National Institutes of Health. Experts in the United States and internationally, they will accept anybody with a positive autoantibody test into their study. They'll rescreen you for free, and they'll also talk to you about research possibilities, but I'm sure they would want to learn more about what's going on with you. So please avail yourself of that free resource. And you might be able to talk to some experts about their knowledge about that specific lab value.
Speaking of resources, are there any in JDRF that we should just know about on this topic if folks are curious after the call?
Yes, the easiest place to find information is jdrf.org/T1Detect. So again, jdrf.org/T1Detect. We link out to TrialNet. We link out to Ask. And I want to highlight, you made me think that question about our mental health, our psychological well-being when we think about screening. There's an amazing program called Ask the Experts at the University of Colorado, Barbara Davis Center. They will talk to anybody about screening. So I would encourage you, you can go to jdrf.org/T1Detect. We have a link to Ask the Experts. If you're thinking about getting screened yourself, if you want to screen your child, if you want to, if you have a positive result and you want to talk to an MD who specializes in autoantibodies, they'll do it for free. So I want to encourage everybody to visit that site. And while I'm at it quickly, Julie,
Go
they
ahead.
also have a study, which is really cool because they're doing it nationwide now. Any child from 1 to 17, they'll screen for type 1 diabetes and celiac disease because there's a connection between the two.
Absolutely. Yeah.
It's free in the US, any child 1 to 17. So you don't have to have a family history. So I just wanted to make sure that was on everybody's mind. It's called the ASK study. Check that out as well.
Wonderful. Thank you. No, that's absolutely no need to apologize. This is all so relevant. And I just am hearing from so many folks as you're talking that this is such good information. So thank you. I do want to pivot to advocacy and just really what you're seeing in terms of around the world here. Is there a policy that's needed? And how can people with diabetes be active on this topic?
Yeah, so I think a couple ways. One, of course, is to talk about it, to talk about the fact that we can detect type 1 diabetes early and the benefits of screening. So share that information. I think also we need to think about how we can move this into healthcare and out of research. I think we need to do that in a way that's safe medically, that provides the appropriate education and the right, again, psychological support. We don't want people to be stressed, but we also want to make sure that we don't slow things down. So I think we need to think about how we do that. So I think talking about it in your community, talking about it with your clinician, your doctor, and talking about it if you happen to be that well connected with your legislator about pathways forward. We need medical guidelines to help support our clinicians who are under a lot of pressure these days so that they have the tools to do this well. And we need to do it as a community. But I think events like this are really important. And I hope everyone who's here goes away and shares this with 2 to 5 people, this information.
I certainly think so. And just even again, to be speaking on things like stages, right? That are
Yes.
New terminology that don't, and to explain to folks that this is, I think so many people, it's news to them that you could detect type 1 diabetes early. I mean, that's just for so many folks, that's not been, their reality. And for many who know about it, including lawmakers, right? Who still have things to learn, like, tell me about this 24-hour-a-day, management of a disease and self-management of a disease, to help them understand that there is this resource and science out there and that's making a lot of progress. And so for them to be interested in it in long term, and sometimes we make that, you mentioned that sort of financial argument too at the start, that was, whether it's paying for that emergency room visit, and sometimes that also speaks to lawmakers. So those of you who are in regular touch, I think that's always a good thing to mention as they're trying to be good stewards of federal or state dollars.
Yeah, and again, your primary care physician, the nurse practitioner you see, again, if you were educated more than, I don't know, 3-4 years ago, this really is, and it's still not part of standard curriculum. So I think sharing this widely is really important. And all of your points were excellent, Julie. So agree.
We're so grateful for your time. And again, this is a deeply emotional topic. It's such, everyone knows where they were and can remember back to those feelings. Those who, and for anybody who's joining us, who's just interested, again, it's so important for everybody to be sharing this information as much as possible. If folks still have questions for you or want to reach out to you after this conversation, could you share the best way to get in touch with you?
Yes, if you want to chat with me, I am happy to chat with you. And if I can't get you the answer, I will find a way to do that. I am at AAO'Neill@JDRF.org. So AAO are my initials, NEILL. So feel free to send me an email directly. I would love to speak with anybody on the call.
I've still got, other questions in the chat, questions in the Q&A that we just didn't have time to get to. So I definitely want people to know where to reach out to you. And of course, folks can always reach out to info@diabetespac.org, and we can make that connection as well. So we'll make sure that folks find a way.
Excellent. And can I answer one quick question that was in the Q&A? And then we'll
absolutely.
all jump
Yes,
off
please.
where we need to go. But somebody said they were misdiagnosed with type 2 diabetes as an adult, and they actually had type 1. So they had type 1, but were misdiagnosed with type 2 diabetes. This happens very frequently. The same labs, these autoantibodies that we use to detect type 1 diabetes early can also be used to address a misdiagnosis in adulthood or childhood. So if you go to our website, we have a list, the names of those autoantibodies. If you've been diagnosed with type 2, you're not responding to therapy, and you think maybe I have type 1 diabetes, you can take that list of autoantibodies to your doctor and ask for those laboratory tests.
Wow, amazing information. I know that is not an uncommon experience. So that is really, really good information.
Yeah.
Thank you so much for sharing that and for all the work you do. Really just such an uplifting conversation around a tough subject, but a lot of really good, positive things on the horizon.
We're going to get this done together. It's going to be a community effort. And I'm just thankful for everybody who spent the time here today, for you, and for our partnership. We're going to move this forward.
Thank you so much. Well, we stand at the ready to help, and I know that everybody listening does too. So thank you so much, and we will be in touch. Thanks
All
for
right,
those of
a
you who
pleasure.
joined. Thanks. Bye-bye.
Bye-bye.